Hello, and welcome to ID Talk, Answers from an Infectious Disease Expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the week of August 15th, and worldwide, as well as the United States and Arizona, the Omicron COVID-19 surge, if you will, has largely plateaued. Slow increase in death rate in the adult population, but nowhere near as significant as in the early days of the Omicron surge. And numbers of cases also have plateaued. Yes, there are still children, adolescents being hospitalized with COVID-19, but by and large, this is being replaced once again by other respiratory viruses, especially this week and last, rhinovirus, enterovirus, with some parainfluenzas, emphasis on respiratory illness, wheezing and respiratory illness, etc., and so forth. Not a huge amount of updates in terms of SARS coronavirus 2 and the response to it. However, some promising news as we look at continued vaccine development. Moderna's dual vaccine, which is intended to be a booster. It contains mRNA both from its baseline vaccine as well as now from the Omicron variants. That has just been approved by the United Kingdom. Anticipation is that it'll come to the FDA for evaluation in September. And every hope is that both Moderna and Pfizer will have a product on the market sometime September, perhaps even October, which will provide dual protection against the baseline coronavirus and then also Omicron subvariant. Numbers are not yet peer-reviewed or released, but the suggestion is that the additional mRNA against Omicron increases the efficacy of the booster vaccine from the mid-50s or so to like 70s or 80s or so. So fingers are crossed that is so. On the other hand, approval of yet more vaccines in today's day and age of COVID pandemic fatigue is not likely to be followed by any huge uptick in vaccine rates. However, hopefully those who are at high risk and those who have not yet been vaccinated can start to be vaccinated with the new products and be that much better protected against Omicron. In terms of the young population, ages 6 months through 5 years, the vaccine rates continue to slowly inch upward, but we're talking not much more than 3% of the possible vaccine recipients in the age group have actually received at least one dose of a mRNA COVID vaccine. So long ways to go in terms of vaccine uptake and outreach. Not a big surprise as, again, the concerns publicly and I think also professionally about COVID-19 largely are being supplanted by other infectious diseases of concern and also related psychosocial and behavioral health, mental health concerns. One question this week specifically related to COVID-19, and it's a great one. What are we still supposed to be doing, thinking, planning, etc., and so forth about children and adolescents who have had a COVID-19 infection in terms of cardiac clearance before returning to school, sports, activities, etc., and so forth? And this is especially important for those patients who are in marginalized populations and either are underinsured or uninsured. It's not such an easy thing to order the cardiology consult, echocardiogram, EKG, etc., and so forth. The good news is that the vast majority of children and adolescents who have had COVID-19, even recently with Omicron, have no cardiac involvement whatsoever. And especially with Omicron, we've thankfully, knock on wood, and I'm doing it right now, we've seen a disappearance of multisystem inflammatory syndrome in children, of MIS-C. And it was those patients, especially the adolescents in the bad days of alpha, beta, and delta variants, who developed MIS-C and had 50% risk or attack rate, even higher in some cases, of significant persistent cardiac disease. In fact, several clinical series now published in retrospect found that 98 to 100% of children and adolescents experiencing MIS-C had some degree of cardiac involvement, and over 50% of those were still experiencing symptomatic cardiac disease 3 months after their MIS-C. However, they all spontaneously recovered after about 6 months or so. So that's both bad news, good news in terms of cardiac involvement with COVID-19. The very overwhelming good news is that MIS-C, again, has largely disappeared after Omicron, and also children and adolescents with severe invasive or multi-system disease related to Omicron variants are numbering at no more than 1% or so. So the suggestion then is that one does not need to automatically perform cardiac screening, cardiology consult, echocardiography, or anything like that in an otherwise healthy child or adolescent who had known or suspected COVID-19. Don't have to do it. Obviously, the recommendation is always to screen for symptoms. So the easy fatigability, tiring out with simple exercises, decreased oral intake, etc., and so forth. Everything which you would normally consider in your screening questions for a sports physical, for even a routine patient. Those, of course, are still very appropriate. And then should you uncover some hits on your questions, to then follow those appropriately. But no longer do you need to consider a cardiology screening of any sort for a return to sports, school, etc., and so forth. So yay, fantastic. If we're looking for a silver lining about the Omicron, that would be that. Why is Omicron different? Once again, because its antigenic structure mutated sufficiently, its interaction with the ACE2 receptor also changed to the point where it was binding preferentially to upper respiratory tissues, which bound the spike protein of the SARS coronavirus 2 differently versus lower respiratory disease. So the whole concept of COVID-associated croup or an upper respiratory tract infection caused by SARS coronavirus 2 Omicron variant, and then precipitating perhaps a wheezing and respiratory illness in those patients with underlying reactive airway disease, all that absolutely makes sense. The fabulous thing is that lower respiratory tract disease, the multifocal, multilobular pneumonia, overt respiratory failure due to viral infection itself, not reactive airway disease, and multisystem disease, all those have by and large disappeared from the pediatric population, not just the United States, but globally. So yay for the good news. That's fantastic. Other than that, though, we still continue to see children being admitted potentially with dual infections, so SARS coronavirus 2 and insert, rhinovirus enterovirus or parainfluenza 1 or 3 or adenovirus or something like that. But they're honestly no different than a usual respiratory season. All right, so enough about COVID-19. Gosh, it feels strange to say that. On we go to other things that are out there. Next question, updates about monkeypox and anything else which is out there. So monkeypox, since we last talked, has continued to explode onto the national and international scene. Here in Arizona, we are close to 200 confirmed cases. Every county has had at least a couple, and obviously the more densely populated counties, I'm thinking here Maricopa, Pima, Pinal, and Yuma, have had a fair number of those cases, numbering almost to 200. Still a almost absolute majority of the patients that are being confirmed are men who identify as gay, bi, or trans women and are participating in multi-partner sex. Yet, again, this is not a sexually transmitted disease, but you could argue a sexually associated disease due to close contact with infective, contagious pox. However, heterosexual cases are emerging, as are pediatric cases. The pediatric patients that have been recorded nationally and also here in Arizona, there's limited information available. As yet, no clinical series have been published. Of course, it's very early. And also, of course, respecting HIPAA and personal health information. But it is suggested strongly that the pediatric patients we're seeing nationally are all infected by close contact with an infected care worker. Or caretaker, I should say. So a parent figure, somebody like that. So that means then that the pediatric patients presenting with monkeypox may have their pox originating in places other than the groin, which is where most of the adult patients are originating their pox lesions. That's problematic, unfortunately, because we are also, as many of you are, I'm sure aware, seeing a nice cluster of Coxsackie virus, hand, foot, and mouth syndrome patients as well. I mean, it is that time of year, and we're going to be seeing lesions of the palms, soles, and also the oral mucosa, which are not due to monkeypox virus, but instead due to Coxsackie virus. Importantly, monkeypox virus, while it does cause and can cause palmar and plantar pox lesions, is not causing significant mucosal lesions. So if you have that child in the office or the emergency department or urgent care or wherever you're seeing patients who has herpingina, that the ulcerative lesions in the palate and or a gingival stomatitis, that is unlikely to be monkeypox and far more likely to be something in the enterovirus family, especially Coxsackie virus. So great for that. That's fantastic. However, we're already seeing an increasing number of children and adolescents who are exposed to a known case of monkeypox. And just as with anybody else in that definition, they deserve post-exposure prophylaxis via the Jynneos vaccine. So, developments since we last talked, the FDA and CDC have approved a modification of vaccination with the Jynneos vaccine. Again, it's a live attenuated smallpox or orthopoxvirus vaccine, which has efficacy against monkeypox. The approval or the approved changes were to now administer 1/5 of the dose to adults ages 18 years and older by an intradermal route versus the full dose given subcutaneously. However, for our patient population, ages 18 and younger, will still get the full dose, the full vial of the Jynneos vaccine given subcutaneously, just as with other sub-Q vaccines. And it is a 2-dose series. So 1 dose within hopefully 6 days of exposure, followed by a second dose 4 weeks after the first. So that's the current approach to provide post-exposure prophylaxis. You may have heard or read about something called PEP++ or post-exposure prophylaxis plus. That concept is providing the vaccines to high-risk individuals who have had a high-risk exposure. So the classic example currently today, August 16th as I record this, is a man who has sex with men who had high-risk sex with more than a single partner in the preceding 21 days. And or travel to an endemic part of the world, which unfortunately means right now many parts of the world, and or had known exposure to an animal which is infected, and that of course is much less likely in the absence of being a veterinarian traveling to parts of Western and Central Africa. So it's unlikely that we will be asked to provide PEP++ to our pediatric patients. Far more likely a true or classic post-exposure prophylaxis for that child or adolescent exposed to a known, confirmed, or strongly probable infected care worker or caretaker. So that's kind of where things stand with monkeypox. Yes, there is a treatment for those patients who have severe monkeypox. TPOXX or tecovirimet is the product name. An antiviral which inhibits replication of the monkeypox virus, just like other antivirals. And just like other antivirals, it's not a holy grail golden bullet sort of fix. Treatment with the tecovirimet does have the potential to limit spread to severe disease in those who are immunocompromised or those who already have a significant disease burden, and it may knock off 1 or 2 days off the 3 to 4 weeks of pox activity which patients are experiencing, but it's not guaranteed to fix somebody right away. This is not an antibiotic which we use in the setting of bacterial pneumonia or meningitis. So current indications for the tecovirimet are those patients who are known to be immunosuppressed or immunocompromised, and here we're thinking especially those patients with HIV and experiencing complications of AIDS, and or those who are receiving chemotherapy or immunosuppressive medications. The other indication, which is a much softer call, and it's unlikely that we're making a big difference, are those patients experiencing severe life-altering pain related either to their pox lesions or in some cases to the proctitis, which about a third of patients are experiencing. And indeed, I would imagine anybody who is experiencing that kind of pain would be desperate to receive and try anything. The challenge is that there are just not enough doses of the tecovirimat to go around to treat every single person fitting those criteria. And again, it's not going to modify or mitigate the pain immediately. So all treatment decisions at this point are being guided through the county health departments of your local area, and the medical or health director of that county health department is making those decisions. You may, as a provider, be asked to be the ordering physician for the TPOXX or tecovirimat and to fill out the paperwork because it is still being released only as an investigational new drug with applications. 3 forms to fill out, including patient consent, which in our PEDS population will be consent and or assent. And it's a significant burden, but it's happening very rarely. And in children, globally, and especially in Africa, and especially parts of Africa where there is what's called clade 2, as it's now known, of monkeypox virus, severe disease, especially in children under age 8, a pediatric age under 8 is an indication for treatment, but that is with the more severe variant, whereas here in this country and mostly worldwide, what we're experiencing is clade 1, or the less invasive, less severely diseased patients. So what's the takeaway from this? Monkeypox is out there. You will be seeing increases in pediatric patients. You certainly will be potentially being made aware of your patients who had or received post-exposure prophylaxis due to an exposure to a confirmed monkeypox case. But the need to treat these patients is pretty low. Thank heavens so far. Okay, that's the update on monkeypox. Fulminant hepatitis. Our patients ages 1 through age 10 or up to age 11 presenting with a viral syndrome followed by liver failure, 10% mortality rate, 15 to 20% transplant risk for liver transplantation. Those cases have largely not disappeared, but largely faded into the background. And in fact, World Health Organization and CDC have been dialing down their active recruitment of cases. It's important to realize that while there seemed to have been a large number, and 1,000 plus, or 1,080 I think was the last estimate of numbers worldwide, a large number of those cases were picked up in sort of retrospective historical assessment of case records. It is not that high of an attack rate going forward. So while I still encourage you to be on the lookout for that child who had a couple days of respiratory and GI viral illness, or what appears to be viral illness, and then develops jaundice and or bleeding, do be aware of the potential yet still for fulminant hepatitis. But the risk for that is significantly lower than it used to be. In those patients in whom you have a concern for fulminant or acute hepatitis of unknown etiology, it is obviously quite reasonable to do the liver panels, to look at the enzymes, to look at the synthetic function via checking quags, albumin, total protein, etc., and so forth. And don't hesitate to contact your local friendly infectious disease provider or gastroenterology provider, etc., and so forth. A bit about etiology. I think you all recall in the early days it appeared that adenovirus 41 was the smoking gun. Now it appears that is no longer true. In fact, barely even half of children had evidence of adeno 41. Instead, there is adeno-associated virus 2, AAV2, which does appear to be present in close to 100% of the patients known and available for testing. What that specific virus's role is unclear. It is almost definitely a cofactor, perhaps triggering a child with genetic susceptibility to viral hepatitis, and then perhaps triggered further into an active disease by some other virus, and it could have been SARS coronavirus 2 or adenovirus 41 or enterovirus XYZ. But as it now stands, that there is no need to go screening every child for AAV2 or even to do additional testing unless they trigger your alarm bells for concern of liver failure or hepatitis. So that's the update on fulminant hepatitis. And then, I guess lastly, I think we've all been following the news coming out of New York and specifically Rockland County, New York, where there was a single patient who was non-vaccinated who developed a paralytic polio, and now the wastewater testing suggests that a much larger number of patients are excreting poliovirus into the wastewater. Not surprising, of course, that the risk of paralytic polio, even in, I guess we'll go back to the 1940s when we were still seeing outbreaks in clusters, is basically 1 out of 200 or even far less. So it's just being infected with poliovirus itself is not a guarantee of developing respiratory failure due to paralysis or peripheral musculoskeletal failure requiring walking assist devices. It's a lower risk. However, on the other hand, 75% of individuals experiencing active poliovirus are asymptomatic. However, they're contagious, and that's the unfortunate thing if they are asymptomatic and contagious in a population which is under-vaccinated. So whereas many of us in the country enjoy a vaccine coverage rate, by age 6 years, just to sort of give a nice to long delay, but a vaccine coverage rate of 98%, which is fantastic. There are parts of the country, including Rockland County, where that vaccine coverage rate is no higher than 60%, meaning there's a whole bunch of patients, young and old, who are at risk as unvaccinated people for developing poliovirus, and while low, there's still that risk of developing significant complications of that. So what does that mean for the rest of us? Now is a fabulous time to capture any awareness of our families about the risk of poliovirus. Make sure that their polio series are completely updated, and if we have children who are experiencing vaccine delay for whatever reason, now is the best time to get them caught up, and to do so overtly with the understanding that we don't want anybody in Arizona to develop poliovirus. So clicks and hats off to the local county health departments in New York and to the CDC for jumping on this hard, but I anticipate we're going to see a lot more news coming out of that specific part of the state in the coming weeks and months. So those are the updates, folks. Other than that, I did mention non-infectious concerns, and this is not a surprise to anybody, but the continued onslaught of mental health disorders, of depression, anxiety, increasing percentage estimates on every case series that I've seen, now anticipating well over a third and closer to 40% of young teens and older teens in our state are experiencing clinically significant depression and anxiety, and especially as they return to school with the challenges inherent in that. All those bear witness to the need to continue our mental health screening questionnaires and just being very open and aware of health concerns in our patients as they come to the office. Also concerning, at least in my county, is an uptick in completed